Okay, let's get started. Welcome to the Health Justice, Organizing Health Justice panel. My name is An Nguyen. I am from Vietnam. I have been living in Philly for 4 years now, going to Temple University.
You?
Yeah,
I graduated from Temple University.
No Al's. So I'm very interested in this topic. Here we have 3 speakers. First is Aurica Hurst, and she is an organizer in Philly. In the middle we have Grabowski, and she is the co-chair of the Socialist Feminist Committee in Pittsburgh, DSA. Last but not least, we have Jen James, and she is from New York Socialist Feminist Working Group. So I will hand the panel over to the panelists. But before I start, I want to keep the panelists keep in mind that the presentation should only last around 15 to 20 minutes max. So we have plenty of room for discussions. If you have any questions for the panelists, please wait until the end. And I will use these time cards to let you know about the time. But let's get started. Aurica, do you want to introduce yourself?
Yes. Good morning. It's morning, right? Yeah. Good morning, everyone. Thank you for coming and being a part of this Healing Justice. I will be talking about the war on drugs, recovery, and restitution from a mindset of a Black organizer. So welcome. Thanks for being here. I'm an organizer. I've been organizing in Philadelphia off the record for about 5 years and being paid to do it for a year. So that's really interesting. I'm also an actress. I like to bring my acting and things I care about into the acting realm. And I also am a writer. So I write a lot about the things that are happening in my community. I'm right here from Southwest Philadelphia, grew up in this area, went to John Bartram High School, and it's really important to me that people are coming out and that we can come together collectively. I'm not in any part of DSA chapter, but I have worked with DSA, and I believe them to be my allies in this fight, my comrades. So welcome and thank you for being here.
Yeah, thank you for those words. So my name is Grabowski, and I, like Ann said, I'm the co-chair of the Socialist Feminist Committee in Pittsburgh, and I was an educator for a decade. I taught middle school, and then I started working in healthcare, and I'm going to be talking about abortion access as health justice. And I've worked with Pittsburgh DSA for about 2 years, and I identify as a socialist feminist, and I'm really happy to be here, and I'm really happy to go over this topic with y'all.
Hey, can you guys hear me? Hi, my name is Jen James. I'm from the New York City Socialist Feminist Working Group. We've been working on the New York Health Act and Medicare for All for about 2 years. And I've also tried to bring healthcare justice, like an expansive healthcare justice perspective into this campaign. So I'm going to be talking a little bit about our Ain't I a Woman campaign, which is about wages for home healthcare workers, NISNA, the NISNA strike that did not happen in New York, or that happened, they won. They got a great contract, but I'll talk a little bit about that, how we can bring workers into this fight. I also would like to apologize. I found out I would be presenting on this panel an hour ago. So I'll try. If I'm rambling a little bit, I apologize.
All right. So I'm going to be talking first, and then we are going to move over to Jen, and then Aurica, and we're going to have questions in between. So I'm going to get started just to get us going. So I'm going to be talking about abortion access as a health justice issue. So just as a little go over my background a little bit, like why am I talking about this? I work at one of those high volume abortion clinics in the country due to restrictions. I work in Western Pennsylvania, and I speak with anywhere between 10 to 40 patients a day, and it is my job to help them access abortion services, prepare for their appointment, and obtain financial assistance, and I also review their medical history. So I listen to patients' experiences every single day, and as I'm listening, it really reveals a complex array of obstacles and a system that ultimately fails patients. And when people talk about abortion access, they often talk about it as like a silo, as its own thing. they don't often connect it to health justice as a whole, and that's what I really want to do, because patients' experiences and everything that they have to go to access this care is incredibly telling about the state of our current healthcare system. So what I'm going to be doing is I'm going to be basically telling a story. It is actually National Tell a Story Day, so this works out really well. And I'm going to tell this story that is meant to illustrate roadblocks, dead ends, complications, and frustrations that are experienced during the process of accessing abortion care or care in general. And I'm going to do this in pursuit of answering the question, how does our healthcare system produce inequality among those seeking care? So in order to do that, I'm going to tell you a story, and I'm going to introduce a character whose experiences are based on the conversations that I have with people on a daily basis. So I want everybody to imagine this person, and their name is Avery. Avery is a single parent of 2 young children. Their work hours fluctuate significantly on a monthly basis. They work one steady job throughout the year and a seasonal job for supplemental income. Some months are more difficult than others when it comes to their finances. They are 36 years old, and they have ovarian cysts that cause them frequent pain and period irregularity, as many people do. They also have a history of high blood pressure, and they take blood pressure medication to keep that under control. They spent almost a decade trying to alleviate their symptoms of headaches and abdominal pain before finding medications and methods that work for them. They received a varied mix of diagnoses before finding doctors that helped them come up with an effective health plan. It was a frustrating process of being dismissed, misunderstood, and left with unpleasant side effects from various prescription medications. One day, Avery sends in their pay stubs to Medicaid as required, and Medicaid rules that they make slightly too much to qualify for state insurance. The letter they receive in the mail reveals that they made only $25 over the cutoff. So they're kicked off Medicaid. This makes them unable to afford both their high blood pressure medication and their birth control. They get Liza, and they opt for the high blood pressure medication, but they still miss a month of their prescription, which results in a high blood pressure reading at a doctor's visit. There are more affordable prescriptions of the birth control pill, and when they call into their OBGYN, the doctor insists that they must come in before writing a new birth control prescription. I want you to consider that the cost of a birth control consultation with a pelvic exam without insurance can cost between $100 and $150. So after their income goes up again the following month, they resubmit their pay stubs to Medicaid, and they qualify once again, so they're back on health insurance, but not without their prescriptions. Then their period is late, but it's common because ovarian cysts frequently mess with their cycle. After 2 weeks pass, they take a pregnancy test, and it is negative, so they think they're fine. Then 2 more weeks pass, and they still haven't gotten their period, so they take another pregnancy test, and it's positive. They do not want to have another child. They begin to worry about whether they can get an abortion, but also they find themselves worrying about the serious health risks that are related to carrying a pregnancy to term. Their 2 previous pregnancies were really rough experiences. They had preeclampsia during both of their pregnancies, which left them on bed rest for weeks and unable to work or even perform household chores. Their last delivery compromised their health even more than the first, and they're worried about their health and the well-being of their children. They keep thinking, what would their children do if something were to happen to them? I want you to consider that the U.S. maternal mortality rate increased from 17 deaths to 26 deaths every 100,000 births between 1990 and 2015. I also want you to consider that the global maternal mortality rate decreased in that same time period 44%. And also, when it comes to abortions, 59% of abortions are obtained by people who already have children and have a pregnancy history. So they're worrying and work picks up again, and Avery spends 2 weeks working constantly and battling internally over what they should do. They feel terrible, exhausted, and sick. They're getting morning sickness and cramps so bad that they struggle to go to work. One day after work, they're exhausted and they Google the word abortion and make an appointment at the first place they find that's near them. It's just down the road from their workplace, and they're relieved. So the clinic can see them quickly, and they're grateful. The staff is incredibly reassuring over the phone, and Avery visits them a week later and receives an ultrasound. The staff shows them the screen, points at the image, and says, "Look at your baby. Isn't it cute?" They begin to feel very uncomfortable and upset. They didn't expect this, and they are taken off guard. They dress after their ultrasound and meet the staff in a room, and they ask, "So when can I schedule for my procedure?" The staff tells them that there's no rush, and they'll call them in a week. They leave the clinic expecting a call from the staff. And a week passes, and the staff calls to check in. Avery asks them over the phone, "So when can I schedule for an abortion?" The staff tells them that they don't do abortions, and she's shocked. They ask if they can refer them to another place. The staff replies, "We don't do abortion referrals." I want you to consider that this location is called a crisis pregnancy center that they went to. 53% of the websites include false and misleading information, and 58% of the websites include false information regarding abortion services. So they go back to the internet and they find an abortion provider finally, but they're more than 2 hours away in a city where they've never been. They call to schedule an appointment. They discover then that because there are so few abortion providers in the area, they have to wait 3 weeks to come in for an abortion. By the time of their appointment, they will be 14 weeks pregnant. They discover that the cost is $815, and the insurance they fought so hard to have won't even cover it. They have no choice but to pay out of pocket. Consider the fact that 90% of U.S. counties lacked an abortion clinic in 2014, and that was in 2014, so it's gotten worse. 14% of abortion patients rely on some sort of financial assistance from an organization, and 53% of abortion patients have to pay out of pocket. Avery realizes how much time was wasted on the uncertainty around their irregular period, and with the time spent at this other clinic that didn't even provide abortions. They are screened for financial assistance at the abortion provider, but the assistance can only lower their cost to $570, which is still an entire month's rent for them. They inquire about sedation, and it costs $150 more. That's so much money for groceries for their family, so they opt out of sedation, even though they are worried about pain. When Avery discloses their high blood pressure medication and their most recent reading to the staff at the abortion provider, they are told that they must continue to take their blood pressure medication, and if the reading is too high the day of their appointment, they might need to be referred to a hospital for the procedure. This increases their anxiety about their appointment, their finances, and their health even more. On top of that, the clinic says that Avery needs to drive the 2 hours to their site for mandatory state counseling several days before their actual appointment. I want you to consider that 18 states require counseling at least 24 hours before an abortion. They miss a day of work to do this, and when they also request off work for their procedure appointment, their employer is pissed. The bosses begin to hint that they can be terminated if they take off more work. This is horrible news because their morning sickness and side cramps have been debilitating, and Avery pleads with their employer to let them off those days, and they allow it, but Avery receives a letter saying that they've been put on an improvement plan because of their attendance issues. They also are required to obtain childcare because children are not allowed in the medical facility. So they have to obtain childcare twice for both the mandated counseling and for their procedure appointment for their 2 young children. When it comes to transportation, Avery can't find a ride for their state mandated counseling visit, so they must call a Lyft. They managed to find a ride for their procedure appointment, but I want you to consider that 45% of Americans have no access to public transportation. By the time Avery's appointment arrives after weeks of waiting, they feel incredibly sick, and they've dropped over $1,200 on medical costs, childcare, and transportation. Despite all the obstacles, frustration, and grief over this, Avery feels confident that this is the best decision for themselves and their family. They are afraid that they are about to lose their job. They are afraid that they will be referred out of their appointment if they have a high blood pressure reading that day, wasting more money and time. They feel ashamed of the situation, and it does not occur to them that they deserved more help during any point of this process. While Avery in this story is a hypothetical person, and we're all imagining them in slightly different ways, it's very important to recognize that the scenario in which Avery is a Black person residing in this country, the barriers in that situation are much greater, in obtaining quality care than they were if they were white. In the US, Black women are 2 to 6 times more likely to die from pregnancy complications than white women. Also, Black women are more impacted by restrictions, resulting in delayed care, increased costs, or total lack of access to care. So, I created this narrative using common experiences that I problem solve with people on a daily basis. I talk with people and I try to help them figure out how to afford the procedure. I try to help them figure out how to get to the clinic. I try to help them to figure out how to afford a ride, how to get childcare, how to do things like cope with the pain that they're going to experience because they can't afford the pain medication, with their health problems and how that is going to relate with their experience. So, even though I'm just telling this story, there are amazing people who actually create platforms for individuals to share their experiences of accessing abortion services. So there's We Testify, which is a program with the National Network of Abortion Funds, and they allow people to share their stories. And what's really wonderful about them is that they center the most marginalized, and they're largely organized and run by Black women. So if you want to check them out, it's We Testify. Their website is wetestify.org, and their handle on Twitter is @abortionstories. And you can also find them, you can find them on their handle @abortionstories. So that's my story about things that I talk about with people on a daily basis. So that is from the patient's perspective. So that's from the patient's perspective. So before we move on to kind of looking at the same sort of situation from other perspectives, like the laborer's perspective, I want to pose the question I posed initially: how does our healthcare system produce inequality amongst those seeking healthcare? So I'm going to repeat that again. How does our healthcare system produce inequality amongst those seeking healthcare? So think about this story. Think about Avery's experience, and I want everybody to turn to the people in their group, because everybody's fairly grouped together at this point. So turn to the people close to you and start talking about how does this process create inequality in our society. I'll give you about 5 minutes and then we'll share answers so you can start the discussion, talk about things that came up in the story and the question and the answers. share their answer or something that they discussed in when they were answering, how does our healthcare system produce inequality amongst those seeking care? My eyes are really bad, so I can't read your name tags. I'll point, I'm sorry. Delilah.
Should I speak from here?
Yeah, that's great.
One of the things our group discussed is how inequality is created in our schools, specifically our sex education. As we discussed from my experience and from Jeremy's, abortion is not, information on abortion is not provided at all in schools, and poor sex education is given, like what preventive options you have, no discussion of condoms or pills and abortion before. Some Natalie's told a story that her sister's school gave them folic acid pills to encourage pregnancy. It said support.
Yeah, so rather than giving condoms or giving, actual other methods, they just preventatively just gave all the girl students folic acid pills just in case they got pregnant, because we had a very high pregnancy rate in our town.
Sorry.
Yeah, and like, what? I know, that's like not okay.
And that takes a lot of money, so it shows, where are they putting the resources rather than buying. They don't want to put the money into giving kids condoms, but they will pay for folic acid.
And another way that factors in
too
is that a lot of times when people find out that they're pregnant, it's like, okay, well, what's the next step? We're never told like how to manage a pregnancy or anything about pregnancy health and what to do. So that's why it's so easy for places like crisis pregnancy centers to take advantage of that, because people don't know what to do. So it's so easy to just manipulate them. Exactly.
In my faith in shop, this Natalie's story came from a small town. So these towns, instead of giving access to information out, limit the financial burden of having a child or getting an abortion. They rather spend limited funds on avoiding the problem. Avoiding that.
Thank you. So who else had their hand up?
Yeah, so Tom works in the medical field as a therapist, mental health field, and we talked a little bit about intersectionality and how basically, like, when a client or a person comes to a healthcare space to receive services, they kind of come as a complete person. So their gender expression, their sexual identity, their race, their socioeconomic class, all of those things are factors into how they receive care. And we also talked a little bit about how doctors prescribe less pain medication to people of color, especially women of color, because apparently we don't feel pain. And those internalized biases, Tom was mentioning that, in medical school or in these medical spaces, they don't talk about race, gender, biases, but they still have them because doctors are people like everyone else.
Yeah, absolutely. Anybody else want to share their thoughts from the discussion before we move on?
Hi, I'm Tiffany. I use she, her. So our group didn't really answer the question. I think we had a lot of abortion care providers, so we just kind of shared abortion stories. But like hearing the story of Avery, I think one of the biggest answers for me in terms of like how do we produce inequality among those seeking healthcare is her being a mom and not being able to bring her child into the clinic. Because like that's really one that even as an abortion care provider, I don't know how to solve.
I know, and I always feel so bad telling them, and then they're just like, there's just so little I can say when that comes up. They're like, what do you mean I can't bring my children? What am I gonna do? And it's like,
is there a medical reason?
I think it's a cisgender straight white male issue, that they're the closest ones to creating these policies over these places. That's what I think.
Well, I think that affects a lot of things. We are told that we don't have the space in our clinic, and it's like we would want to take them to a separate room so that way it doesn't bother other people, because seeing children is not really an appropriate place. But we don't have extra rooms, so we're like in this tiny little building. So it's like the fact that cis white men are making these decisions, the fact that we don't really have a lot of money, we're just like in this little tiny building. It's like a kind of a couple factors. But sorry,
No, yes, I mean, I totally agree with something like that. Like, I feel like I've been trying to like dream solutions around this. Like, what would we do? Like, we also have like a small building. Like, would we create like a child care center downstairs? Like, how radical would that be to be like, moms have abortions, but then every patient walking to the abortion clinic is in this like super happy child care facility.
I know.
And they don't necessarily want a child. And that's an interesting thought process. So I don't have a solution.
Yeah. Thank you though for sharing that. So at this point we're going to move on to Jen.
Yeah. So I'm going to talk, now that we've spoken about like patients and their experiences with accessing healthcare, I'm going to talk about things from like the labor aspect of, so I'm going to talk a little bit about SocFem's Ain't I a Woman campaign, which is trying to get fair wages for home health workers. And then I'm going to talk a little bit about the NISNA strike, and then I want to see if I have some time, like sneak in Decrim NY, which is about, providing decriminalized sex work, which I think will, sort of lead into what Aurica, am I saying that right?
Oh,
Aurica, thank you, is going to talk about in her talk. So Ain't I a Woman is a campaign we endorsed pretty recently. We're trying to get fair wages for home health workers. Right now in New York, home health workers work 24-hour shifts, which is insane, to work for a full day and night, and then on top of that, they are only paid 13 hours of that 24-hour shift. How is this even possible, right? So they're not making minimum wage. They're not able to live lives with their family. All of us have existence outside of our workplace. At least we should. Right, and home health care workers, they tend to be low-wage immigrant women, who are expected to just work days upon days. And the reason for this is, of course, cost, because 24-hour care can be very expensive, particularly for people who may be retired or may be disabled, probably don't have a lot of income on their own. And so there's really been people have really been pitting patients against workers in this fight, saying that we can't pay people fairly because it's gonna affect patients and their access to care, right? And this is why we're all socialists, right? Because we all believe that we can't pit poor people against each other, that we have to work together for our own liberation. So, nobody is being helped here. How well can you take care of somebody if you're working 24 hours straight, right? And you're not being paid well on top of it. So, it's been very disappointing. Even to the point where it's been hard to get legislative support on it because none of the unions support this, which is a whole nother thing. Some home health workers are unionized and their union isn't doing jack shit about it. And certainly none of the other healthcare unions have really been terribly supportive either. And so I think this is an important fight that we're trying to draw attention to, because it's just so obvious. Why are we, you have to pay people for their labor, right? And the excuse they say is people are, we don't have to pay them for these 11 hours because people are sleeping or doing things, but obviously you're there. You have to be there, right? It's not like you can leave. you know, even if you're sleeping, you have to be like alert enough to like, maybe they need help, or, you know, your patient needs help during the night. Yeah. So the whole thing is ridiculous. Recently we have been fighting in the court. We had won a court case saying that this was like obviously illegal and they needed to get paid for the full 24 hours, but then it lost on appeal. So we're trying to like figure out what the next step is. I think we're going to try to do legislation to stop this blatant wage theft. And right now, I mean, I can go in and talk a little bit about like what DSA is doing, but it's mostly like education and like bringing awareness about this issue, especially because we're the 89 Woman campaign is like a coalition effort and we are just like a supporter of this. So as DSA, I think we're trying to support and bring attention to these issues. Yeah, so that's one of the campaigns that we're working on. We were also doing strike solidarity support with the niceness strike.